So let's then pick up where we left off for our fellows. We were, of course, talking about the management of hyponatremia. We decided, or we already parsed the discussion around rate of correction, risk factors for osmotic demyelination. We now can move on to the rest of the management of hyponatremia. And that certainly includes, well, once you've defined the risk factors for, or once you've defined rate of correction that's desired, for those individuals that you decide to correct slowly, you now need to find risk factors for overcorrection and then institute measures to mitigate that overcorrection. Okay, so most chronic hypotonic hyponatremic patients will correct slowly, okay, except for the following clinical scenarios. So as you're parsing the consult for hyponatremia, you can take your time in addressing that case of hyponatremia, severe hyponatremia, unless you are facing these three different variants of hyponatremia. Severe hyponatremia that is from hypovolemia. We've already talked about the pathophysiology in that scenario. ADH is high because of activation of baroreceptors from the low ECV, from the hypovolemia, okay? If you were to correct that hypovolemia, you'll suddenly shut off ADH. ADH being off results in dumping large amounts of free water. So that hypovolemic, hyponatremic patient who gets that liter of fluid down in the ER, that needs to be prioritized. That patient needs to be seen quickly in order to mitigate the risk of overcorrection. The patient who has polydipsic syndromes, so the most simple of which is primary polydipsia, beer potomania, and Tiantos hyponatremia, as we already covered, are variants of that. So simply stopping the excess free water will result in a sodium that blasts off, right? The sodium rapidly corrects in a primary polydipsic patient who all you do is stop that free water intake. You'll notice that they're peeing, half a liter an hour. Those are patients that are at risk for overcorrection. Those are patients that need to be prioritized to be seen quickly if that consult rolls in. This is a rare variant, someone who has adrenal insufficiency, and that adrenal insufficiency is recognized as soon as they get glucocorticoid replacement. That can shut off ADH release, and therefore that patient can develop a vigorous aquaresis and the sodium rise quickly. Now that, of course, is going to be a pretty rare type of hyponatremia that you encounter. Now, for all the other chronic hyponatremias where sodium is 118 in a heart failure patient or cirrhotic patient, those, as long as they're not seizing, those can be taken on, when you have time. But these others, you need to try and inject yourself into their case early on because they can overcorrect quickly. All right. Now, once you identify these patients at risk for overcorrection, you can address that risk through one of two strategies. Okay. I personally prefer the first. Give them DDAVP. That will ensure that aquaresis does not suddenly ensue, and then correct the dysnatremia, the hyponatremia, with a 3% saline infusion, okay? That will predictably raise the sodium. We already discussed the tools that you might use to prescribe the rate of 3% saline that you want to give. For instance, we talked about the Androgy-Medeus equation, right? That would be a tool you can use. I highlighted how the Androgy-Medeus equation is flawed because it doesn't account for the losses of the patient, right? It's just you give the patient this fluid and the sodium will rise by this amount, right? We talked about the Androgy-Mendeus equation up here. Now, as soon as you give them DDAVP, they become that somewhat closed box system. And so you can use Androgy-Mendeus to predict the rate of rise of 3% saline and prescribed accordingly. Okay. Now, let's say you guess wrong. This is a patient who doesn't have primary polydipsia. Let's say this patient is not hypovolemic, is actually a heart failure patient. Let's use that example. They have a low urine sodium, right? That tells you low effective circulating volume is present, right? But their low effective circulating volume is not from their hypovolemia, it's from heart failure. What happens if you give a heart failure patient desmopressin? Well, nothing essentially. They have high ADH. That high ADH is not essentially modifiable because they have pump dysfunction. And unless that pump dysfunction is modifiable, the ADH excess is not terribly modifiable. Giving them DDAVP will cause no harm, is what I'm trying to say. Even in a space of uncertainty, if you're worried about overcorrection, you're not quite sure whether this is one of these three, right, or not, it will do no harm to give a patient with heart failure some desmopressin, and you can give them 3% saline, right? So those are things that you can use even in a more messy scenario where the clinical picture is incomplete, okay? Now, again, here's your Androgy-Mendeus equation. I was looking back for it, but it was right in front of my face. You'll, of course, need to know the electrolyte content of 3% saline in order to plug and chug what is the delta sodium when you give 1 liter of 3% saline. The K will be 0. You'll have a starting sodium. And so that will be a fairly straightforward problem to solve, okay? The other solution is to try and track how much free water they're excreting in this very dynamic situation and try and replace some component of that free water in the form of oral or IV free water administration. That is certainly less controlled, right? Because you have no certainty over how much free water they're going to excrete. So they're a dynamic situation. You have to check them frequently. You have to know in real time how much urine they're making. Theoretically, you'll need to know the electrolyte content of that free water or of that urine that they're excreting. So this to me is a more messy scenario. I don't use this much. Others amongst us would espouse the use of this second strategy of mitigating an overcorrection, okay? I generally prefer the first, okay? And then these can usually 3% saline, you'll need at least at Parkland, you'll need a step down unit in order to give it. So there are some barriers to implementing the first solution that are center specific. Now, once you've sort of mitigated the risk of overcorrection in those patients that have a risk of overcorrection, we should do the other things that are going to help you raise the sodium, right? You obviously need to make sure that a patient is fluid restricting. Whenever you're hyponatremic, fluid restriction essentially needs to be part of the ingredients of your solution that you implement, right? And it's important, of course, to look for occult forms of free water intake, things like ice, things like fruit intake, which is essentially 90% water. These are things you need to search for in order to implement a real fluid restriction. I would say that at least 50% of my hyponatremic consults are finding some source of free water that the medicine team didn't recognize and then taking that off the table, right? So look for those other sort of occult sources of free water that maybe the patient or the other non-nephrology providers do not recognize. Okay, correct the potassium deficit. Edelman's equation, of course, we've gone over Edelman's as an ad nauseum. For our visitors, I'll just show this central equation of dysnatremia, where plasma sodium is equal to the sodium content in the body over the water in the body. And so from this formula, one can see if you have a potassium deficit, this quotient falls. And so I should correct this potassium deficit. So said straightforwardly, giving potassium raises my serum sodium. That's predicted by Edelman's relationship. And so if you have a K deficit, you should certainly correct that K deficit. Even if the plasma K is normal, if you have an inkling that there's a K deficit, remember that plasma K is a measurement of only 2% of your total body's potassium content. 98% of total body potassium is inaccessible to direct measurement. So if you have the impression that somebody has a K deficit, go ahead and give them K, okay? Step 4, all right? Enact tailored interventions addressing the specific cause of hyponatremia, okay? So if there is nausea that's causing that non-osmotic ADH release, give them antiemetics. That's typically not the only thing that raises an ADH. I mentioned that to you. It can be part of a sum total of excess ADH, but it's usually not the sole explanation for ADH excess. If you're dealing with a case of SIADH, right, we have ways we can address that. We've talked about these things multiple times. We can increase free water excretion by increasing the amount of osmoles that they must excrete, right? So we've gone over this formula multiple times. Osmoles excreted over urine osmolality is how we can calculate urine volume. So if I want the patient to pee more free water, one way, if I cannot modify the urine osmolality because of SIADH, if ADH is unmodifiable, one way that I can try and excrete free water more effectively is by augmenting the obligatory osmoles that they must excrete. And so increasing their protein intake, which ultimately is metabolized to urea and is an osmole in the urine, or sodium and potassium salt intake, then those would be ways I can expand the urine volume and enhance free water excretion. We now have urea tablets that we can use. You can use salt tablets as well. And I make that point. I've made that point before, and I'll make it once more again. When you are giving salt tablets to a patient with hyponatremia, you are not so much as correcting their hyponatremia by augmenting the numerator in Edelman's relationship, because if I give you salt, you pee out more salt, right? You don't keep it. So when I'm giving salt tablets to an SIADH patient, what I'm essentially doing, I'm not increasing their total body salt content. I'm simply shrinking their total body water by increasing their urine volume, right? That's how I'm actually solving this case of hyponatremia in the chronic phase of managing SIADH with salt or urea tablets. I might consider the institution of loop diuretics. We've gone over the fact that loop diuretics are somewhat schizophrenic. They can lower sodiums. They can raise sodiums, right? I think that was one of the problems in the problem set. So that is a tool that you can use. It doesn't always successfully increase free water excretion. It will tend to do that as long as you do not overly volume contract a patient, right? If I volume contract somebody with loop diuretics, I may increase ADH release, right? I may also, we've gone over this, increase free water reclamation in more proximal segments of the nephron. And that would reduce my serum sodium if I did both of those things. So when I'm using loop diuretics in a classic SIDH patient, I want to avoid hypovolemia. And in that regard, I also want to avoid K depletion. If I can do those things, I might reduce my urine osmolality as a net effector mechanism of correcting the dysnatremia. Okay, we've gone over that physiology before. You recall that the medullary hypertonicity is half urea, half sodium and potassium salts. The sodium and potassium salts come from thick ascending limb transport, right? So I can reduce the medullary tonicity by using wisely a loop diuretic. 3% saline or vasopressin antagonists are generally only for, obviously, for short-term use, okay? This is really a transient measure when conservative measures fail, when sodium is falling or patients are typically very symptomatic. Again, vasopressin antagonists are approved only for short-term use. Even if you tried to prescribe it after discharge, they're exceptionally expensive. They're not easy to get. And so I don't think they really have all that much usefulness. I personally have never prescribed vasopressin antagonists to treat a dysnatremia. With all the other tools I have, there's no reason to cross that bridge for me. Okay. All right. I should go over this principle. It's certainly a principle that is important, as well as a way you can impress your resident colleagues about the majesty of nephrology when you teach them this concept. Did you know that when you give normal saline, which has a sodium concentration of 154, you can actually worsen a case of dysnatremia with a sodium concentration of 120. Okay, so let's go over how this may happen. This doesn't intuitively follow. It should go up if I give a fluid with a sodium concentration of 154. Well, you should be able to explain to your resident that, well, let's suppose your urine osmolality, because of SIDH, is somewhere around 600 milliosmoles per liter. And you give them a fluid which contains roughly 300 milliosmoles per liter, okay? Then, theoretically, they can take all of these 300 milliosmoles, which you gave them in 1 liter of water, and dump it in a mere half a liter of water, right? Because their urine is twice as concentrated. So they dump all that salt you gave them in half a liter of water. They hold the other half, and the sodium can drop. Okay, so this tipping point happens when urine osmolality is greater than this serum, the fluid osmolality of the fluid that you administer. Okay, that's where that theoretical tipping point can happen. In practical approach, this really doesn't happen unless you have an osmolality that's around about 500 to 600, in the urine osmolality of 500 to 600. And that is because none of us can put a hold on urea excretion. We'll say, okay, you gave me salt. Well, I'm going to hold off on excreting any urea for now. I'm going to take all that salt you gave me and I'm going to dump it in less than a liter of urine. And then I'm going to resume urea excretion, right? Urea always crowds out the space for salt elimination in the urine, okay? And so this tipping point doesn't happen as soon as urine osmolality exceeds the crystalloid osmolality. This tipping point empirically happens when urine osmolality is roughly 500, 600, and the IV fluid has an osmolality of around 300. Okay. SGLT2 inhibitors, now, we prescribe it for pain of the great toe, everything under the sun, including hyponatremia. So theoretically, you can also enhance free water excretion through the glucosuria, right? Glucosuria is an osmotic diuretic. And so you can enhance free water excretion by causing obligatory glucosuria through the use of SGLT2 inhibitors. There's even a couple of very small studies that still got published in JASN on this topic, okay? The use of lithium and dimethylcycline as a means to essentially cause DI is really a very aggressive intervention and is not often used at this point in time. So I would say that's a rare tool that we take out of the tool shed, okay? For hypervolemic states, where I have low effective circulating volume, right? The far too common heart failure, cirrhotics, generally your tools are fairly limited beyond simply tightening up the fluid restriction, okay? Now, if a patient is hypervolemic and you're trying to augment electrolyte-free water excretion, you might do that through the judicious use of loop diuretics. Remember, again, that's a schizophrenic move. You've all had personal experience, certainly in during residency and early fellowship, where you give somebody a loop diuretic and their sodium falls, right? So this is not always successful. It really just depends on whether that loop diuretic results in a net loss of Edelman's denominator faster than Edelman's numerator, right? In the dysnatremia. You now have the ability to add SGLT2 inhibitors. You have the ability to avoid thiazide diuretics. Remember, thiazides are going to predispose to first worsening hyponatremia. So if you have somebody who's hypervolemic from heart failure and hyponatremic, you certainly want to use more loops and avoid thiazides. Replete any K deficit if you think there is one, even if the potassium is relatively normal, okay? Now, if somebody is truly hypovolemic, is a heart failure patient who was diuresed to the point of hypovolemia, right? You should obviously consider stopping the diuretic in that scenario. We don't always keep our foot on the gas, even though cardiology may want us to do that. And then you have the vasopressin antagonists. I've told you again, I've never had to use it. But it's a tool for short-term use. Notice that I'm not including urea as a tool that you should consider using in this group. Let's think about why that is. Well, what happens when you give urea to a patient with low effective circulating volume? Well, you're hoping that in giving urea, you are enhancing free water excretion because urea is an osmotically active particle that ends up in the final urine. But if you give somebody with low effective circulating volume urea, what happens is they don't excrete all that urea. Remember, their nephron is avid for urea. In fact, you use a fractional excretion of urea as one measure of circulating volume, right? If somebody's on diuretics, you say low Phe urea is a sign of low effective circulating volume, right? So all these heart failure patients and cirrhotics have low effective circulating volume. They have low Phe urea. So if you give urea to a heart failure patient, more than augmenting their urine output, you'll augment their BUN, right? All patients that you give urea to have an uptick in their BUN. If you have urea avidity, or the nephron is urea avid, then that uptick just dramatically goes up, okay? And so you'll have less effect of administering urea. Now, at some point, if you just keep going forward with urea, you will eventually hit a new steady state where the BUN is up higher and you're in balance. urea input is equal to urea excretion. So at some point, you are going to tilt the balance towards more free water excretion. It's going to be at the expense of, it's going to be delayed, and it's going to be at the expense of worsening azotemia. Whether or not that's harmful or at least frightens other doctors is what you'll need to consider on the side. Okay, so again, I would argue urea shouldn't be part of your toolkit in managing these patients with low effective circulating volume. Okay, for cerebral salt wasting, I think I touched upon this very briefly, and we'll round this out, move to dyskalemias. We want to kind of Goldilocks it. You can't just withdraw all fluids from this patient because they're hypovolemic. So in general, we're trying to repair the volume deficit. That requires some fluid intake, either IV or orally, in combination with salt. Okay, we want to augment the effective circulating volume, either with, again, oral or IV measures, right? I've already told you, however, that if you expect that cerebral salt wasting should turn off their ADH excess as soon as you give them their 2 or 3 liters of saline, that almost never happens. Okay. And so there's something more complicated with cerebral salt wasting than hypovolemia causes excess ADH, which causes hyponatremia, right? Because you can't really turn it off. That's why some people question whether this is really deserves a separate name, or is this simply kind of a flavor of SIDH, okay? Sometimes we give fludrocortisone. This is a mineralocorticoid. You want to avoid what happens if you give mineralocorticoid to somebody's potassium. Their potassium tends to fall, right? Just like primary hyperaldo patients. So you'll have to watch that potassium if you're going to use Florinef, because K depletion tends to cause worsening hyponatremia. Okay. Often this is a temporary effect over weeks timeline, where the ability to regulate free water excretion is restored after the insult. Okay.